I think we'll start now. Thank you again for joining us today. We are thrilled to have you all here as we dive deep into this topic of TB in children. I'm Shaili Gupta from MSF Access Campaign, your moderator for today's webinar. And we have an exciting line of speakers and discussions moving ahead. While there are many tools, new tools and treatment available now, for tuberculosis and its resistance forms, the situation remains grim when it comes to TB in children. As we continue to see glaring statistics, a child dies of TB every 3 minutes, and more than half of children having TB never get diagnosed. WHO in 2022 came out with this guideline for pediatric TB management to help improve diagnosis and also quality of care among children with TB. Taking this opportunity, we as MSF launched TACTIC project. TACTIC stands for Test, Avoid, Cure TB in Children. We launched it in 2023. The whole idea of this project is basically to support our teams in more than a dozen countries in Africa and Asia to implement these WHO recommendations, and also use this as an opportunity to advocate at national and global level for basically calling for more resources for speedy implementation of these recommendations at country level. Today, we are actually here to talk about this report that we have launched today. Basically, it's a survey of policy guidelines in 14 countries looking at pediatric TB to basically assess the national policy frameworks and see if they are implementing and have adapted WHO guidelines, and also look at the challenges being faced by national TB program. Our team is going to present the findings and data on this report, and also will share key recommendations for stakeholders. This will be followed by two of our colleagues sharing their experiences of working in the field in Sierra Leone and also Philippines. We also have three eminent panelists who will be sharing their views as representatives from community, National TB Program, and also WHO. And it will then be followed by Q&A. Before I hand it over to our first speaker, I have a few housekeeping announcements. The webinar is being recorded, as you can already see, and we'll be sharing it afterwards with all participants. All participants other than speakers have been muted. Sorry about that. It's a little difficult to control otherwise. But we're trying to keep it as dynamic and informal as possible. So feel free to post your questions and also comments, ideas, opinions in chat. The event is going to run in English, but there are speakers who can answer you back in French. So feel free to put in your questions in French as well. I already see a lot of you introducing yourself in chat. Thanks, keep it going. So as I said, the idea is to keep it as dynamic as possible. And we'll take questions even during the presentations in case speakers feel like answering back to some questions. But we will have 20-25 minutes towards the end for all of you to ask questions. And now I'd like to invite Daniel Martinez Garcia, who is leading this TACTIC project, to give us an overview about the project. Thank you. Over to you, Daniel.
Thanks so much for the introduction. So I'm going to try to be as concise, and I'm happy to see already 150 people connected. And so I'm preaching to the converted. We're gathering here to confront a pressing and an historical global health crisis, and it continues to plague what I consider are the vulnerable among the vulnerable, which are children. And we say that a lot in many topics, but here there's actually data. So the majority of children that have TB remain undiagnosed. So it remains the most overlooked group in this epidemic. So a key figure that remains quite incredible is that 96% of the children who died to this disease were never given the treatment that they needed, and those treatments exist. To compound this crisis is that the new shorter treatments for children, they're not widely implemented. So the coverage gap remains. So 37% of eligible household contacts receive preventive treatment only. And if you check at the youngest children, we're talking about only 48% of children under 5 and still 30% of under 15 are not receiving the care they would require. So we think that we need to come with some solutions. So WHO has been leading the way. In 2022, as you said, they came with new recommendations and a roadmap. And it was a unique opportunity to shift the way we have been diagnosing and treating TB in resource-limited settings. And in particular, I'm talking about non-vertical programs where we are doing general care of children. So the concept that WHO put in the table was to put more children under treatment with a simple clinical algorithm and promote, for example, stool testing to facilitate diagnosis and treatment. And this approach is vital to reduce the incidence of severe disease among children. If you put them early, there's going to be less severe disease. The second element was to use shorter treatments, adopting the 4-month treatment plan. For the majority of children, they can use that, and to use what already exists, the child-friendly formulations. And this can really make a difference. It's much easier. And for those that still don't have symptomatic TB, the household contacts, to implement shorter preventive treatment of 3 months. So that would make a big difference because we know that we have this window of opportunity if we identify early the household contacts. So tactic appears in MSF to try to address these gaps in pediatric TB through 3 key pillars. I'm talking again here in non-vertical TB projects. So the first one is what we're saying here, implement the WHO recommendations and the algorithms. So we're doing that in a phased approach in different countries to scale up the efforts and eventually might be able to show a way for the humanitarian sector in that how we can actually use this clinical recommendation to reach those who need the most, but understanding that every context and reality are different. So that's the first one. The second one is we have a very strong operational research component to try to understand the feasibility and acceptability of these recommendations. The recommendations are very clear and very easy, but it's not easy to know when to use them, how to use them. It might create a burden or a perception of burden of an increase of number of cases in a place that might not have the resources. So we actually need to do it in a way that we understand those limitations. And the third one, and is why we are here, is the advocacy component. It's crucial to raise awareness and to secure more resources for the children that are affected by TB. And we need to understand where they are in terms of policy, where this is the focus of the report that we're going to be presenting, and use it as a foundation to move forward. So we see that it's crucial to recognize the role of advocacy in national TB policies to tackle pediatric TB. Without that, it's difficult to change. So understanding how this policy will shape the management of TB in children will be key to implement effective solutions. So this is the way we're trying to advocate for child-centered approaches to drive meaningful change. So this is just a general introduction, and now we're going to go to the important part of this webinar, the survey. Thanks so much.
Thanks a lot, Daniel. Before we head to, as Daniel mentioned, the findings of this report, I'd like to introduce our 3 speakers. We have Sten Dobergraver, diagnostics expert with MSF Access Campaign, Gabriela Ferlazzo, TB medical advisor, and Christophe Perrin, TB advocacy pharmacist. All 3 of them are with MSF Access Campaign to take you through the survey findings and recommendations. Thank you. Over to Sten.
Yeah. Thank you, Shelley. And first of all, warm welcome to everyone. I'm super glad to see so many people joining us and to discuss and to brainstorm here in the webinar on pediatric TB, the challenges, but also the ways forward. So what I will do now is, together with Gabrielle and with Christophe, is to take you through the survey. So this is part of the advocacy, as Daniel has explained, and it all starts with policies, of course. And as Daniel explained, in 2022, WHO updated the guidelines for pediatric TB, which are evidence-based. So WHO makes recommendations based on evidence published, and it's important that national policies adopt those guidelines from WHO as a first step to facilitate implementation. Next slide, Adama. So we know it takes time to adopt national policies, but because it's such a critical step that policies are updated based on WHO recommendations, we have done this survey, but also looked into status of implementation. We have done that in 14 different countries. You see the list here. These are countries with a high burden of TB. These are countries where we also provide as MSF TB care. We also had a close look to a high-income country, not as part of the survey, but as you will see it in the report, as a standalone box. Because we know there are also children with TB in high-income countries. We have a TB project in Poland, mainly providing care to Ukrainian refugees. But you will see when you look to the report after the webinar, there will be a specific page on the challenges of providing TB care in a high-income country such as Poland. So about the survey, we have used a methodology which we have made as solid as we could. You will see in the WHO recommendation from 22, there is quite a bit of recommendations. So the first thing we did with the core team, we selected the recommendations that we feel and see as MSF critical to be adopted in the national policies and also to be implemented. So we came up with a list of 8 policy questions, and then we also had 11 implementation questions, because we are nothing with a policy on the shelf in the capital if there is no procedure towards implementing the policies and to really see change on the ground. So we came up with 11 implementation questions. It's important to understand also the limitation here, because we were not able to go to every single facility in every of the 14 countries to see if manuals are in place, if training is in place, if the pediatric formulations for a certain drug are in place. So we used a proxy, and what we did, we worked with the NTP to understand if they have the materials available at the NTP level to facilitate implementation in the country. So it's important to understand that limitation. So how did we do it? So the first thing, of course, we engaged with MOH NTP, worked with them on the process, and got their approval to join the project, which was positive in all 14 countries. And then MSF teams, they collected all the national guidelines of the 14 countries, either publicly online. If they were not public, we reached out to the NTP, and we pre-filled the policy surveys, so the 8 policy surveys, because those responses should be in the publicly available national policies. For the implementation questions, we went to the NTP, and the first thing that the missions or our colleagues in the countries did when they met with the NTP was first validate the policy questions, and then secondly, get responses to the implementation questions and complete the survey. Then the MSF team reviewed all the responses. We searched for clarifications from the NTP when needed. And then when we had the final version, we went back to the NTP for the final validation from their side. So that's how we did it. You will see, if you look at the report after the webinar, you will see that we compiled all the data in a big dashboard. So it's a 2-page spreadsheet where you will see the 14 countries, where you will see the 19 indicators, and we use the color code to make it easy for you to understand the gaps or the alignment with WHO recommendations. So it's a traffic light system that we used. So meaning basically, when you see a green color, it means yes, the policy is adopted, but also the materials to facilitate implementations are also available at the NTP. Then it's a green. An orange, it's a bit in between. Policy is updated, but the material is not available or not yet available at the NTP level. And no is a red, which means basically no policy adoption yet for that specific indicator. About the materials available at the NTP, you will see in the dashboard, I mean, depending on the indicator, for instance, for gene expert on stool testing, we looked into SOPs, manuals, training for facilities. When it comes to the medicines, we looked into procurement data. Or the country actually procuring the specific pediatric formulations, for instance, of a given drug. So that's about the dashboard survey. Next slide, Adama. So now let's look to the data. I will go through the diagnostic sessions or chapters, then I give it to my colleagues for the other chapters. When you look to diagnosis, we selected 3 WHO recommendations we feel as MSF is critical. The first one, to be able to treat a child with drug-susceptible TB treatment just based on clinical evaluation, and that we don't have to wait for a positive gene expert test, for instance. The second one is to adopt and use the treatment decision algorithms. So TDA means treatment decision algorithms. And these are clinical algorithms which you will find in the WHO handbook for pediatric TB, which are evidence-based and which help physicians, healthcare providers to make that assessment based on clinical symptoms when whether a child should receive treatment or not. So these are very useful algorithms to facilitate the use of treatment in children without a bacteriology or a gene expert test. The third one is gene expert on stool. So stool has been added to the series of specimens that can be used to do gene expert on clinical specimens from children. We have sputum, we have gastric aspirates, etc. So stool was added recently based on clinical and scientific evidence. So we also measured whether national policies are also using or recommending to use stool testing on gene expert. We know sensitivity for stool testing. We all know it's not great, but none of the diagnostic tests for children have a super high sensitivity. So we feel it's important to also give the opportunity and the chance to the physician, but also to the lab to test on stool testing. So when you look to the data for the different countries, you see we are not doing so great on diagnosing TB in children. Some countries do have their policies aligned and do have the materials available. Some countries are in between with the policies fully aligned for those 3 indicators, but not having the materials. And a few countries don't have the policies yet aligned with the WHO recommendation. We, as Daniel explained, we also implement ourselves in the countries these 3 indicators. We have evidence, and we see it every day, how important it is to be able to use these 3 indicators in the way we diagnose TB in children. So we encourage, of course, countries, national programs who are not fully up to date with those 3 indicators to close the gaps as soon as possible and seek the support to do so. Because we see every day in our clinics, we can find much more children if we implement those indicators in our facility compared to without. I will stop here for the diagnostic session or chapter. I hand over to Gabriela to take you through the data on prevention.
Thank you. Thanks, Stijn. And good morning, everyone. It's really a pleasure to be here. So I will take you to the results, through the results of the survey for what concerns TB preventive treatment. And as Stijn was saying before, we had to choose our battles and select some indicators. So for TPT, we chose 3 main indicators. And the first 2 looked into policies and procurement of shorter treatment options, specifically 3RH and 3HP, in 2 categories of eligible people. So children less than 5 contacts of bacteriologically confirmed PTB, and children and adolescents with HIV. So I will talk about the 3rd indicator a bit later. So as you can see from the dashboard, the results are quite encouraging. And all countries include in their policies at least one of the 2 shorter options in children under 5. And the NTPs reported that the needed drugs to implement the regimens are procured. What I can add, we have all the data and with the details. What I can add is that the vast majority of countries recommend in their policies 3RH. We know that 3RH has been there for quite longer than 3HP, and but also about 40% include 3HP in their policies in children under 5. When we look into children living with HIV, you can see that only very few countries do not yet have policies recommending shorter options for eligible children and adolescents, and they still recommend isoniazid preventive therapy options, whether standalone or in combination with cotrimoxazole. More or less in children and adolescents living with HIV, about 50%, so 7 countries include both 3RH and 3HP as an option in this category. To note, no, wait a second, Adama, sorry, go back. To note that at the time of data collection, the latest WHO TPT recommendations were not out yet. They just came out in September 2024. And 3HP was not yet recommended in children less than 2 years old, nor the pediatric formulation of rifampicin was available. It only came out more recently. So this can contribute to the fact that several countries did not move entirely toward a 3HP option in the categories that we looked at. The last indicator is the easiest one, I would say. So we looked into whether TPT could be offered without a positive TBI test for TB infection, and so either TST or IGRA. And as you can see, all countries allow for TPT initiation without the need of a positive test. All this, of course, no need to say after ruling out active TB. So I would say that in summary, results are quite encouraging, but we also know that the global data show important gaps in the scale up of TPT in children and adolescents. So we hope that this new guidance that just came out together with the new child-friendly formulations of rifampicin will help to address the remaining gaps. There will be other things that need to be done, and we can discuss later, maybe in the debate. But for sure, this the fact that there is not any more restriction in children less than 2 for the shorter once-a-week 3HP will surely help to overcome some of the gaps. And we do encourage countries to move toward the shorter TPT options also in children living with HIV, as we know that there are higher completion rates and they're more acceptable by children and their caregivers. I will stop here and leave the floor to my colleague, Christophe. Happy to take questions at the end. Thank you.
Sorry to interrupt, but Christophe, if you can just make sure that you don't use acronyms when you're talking. There are a few panelists who participants who are not really aware of all these acronyms. So thanks.
Sure, Shelley, thanks for this morning, and hi everyone. So I will take you through the outcomes of the survey relating to drug-sensitive TB, and starting with the 2 key criteria that were measured in the survey, starting with whether the 14 countries had updated their national guidelines with the WHO recommendations to move ahead with a 4 months only regimen for children with non-severe drug-sensitive TB. And the second criteria is linked to the availability of existing pediatric formulation that are a combination of rifampicin and isoniazid, rifampicin, isoniazid, and pyrazinamide, and also the pediatric formulation of ethambutol. And you see that most countries are doing pretty well there for drug-sensitive TB, at least policy-wise, which is comforting. But just I would like to introduce, based on what Stein mentioned before on how the survey was developed. Actually, it's for all this country in green there, they should consider that as an encouraging move. It means the policy is updated, it means the formulation are there, it means the SOP available, but it doesn't mean, unfortunately, that every single TBL structure, well, a child or even a standard structure, because Danielle mentioned that we are talking here in the survey about non-vertical TB projects. I mean, it doesn't mean that the formulation, the pediatric formulation for drug-sensitive TB are available in every single structure well child. with TB could deserve TB care for could deserve TB care. So just a little warning that green is an encouraging move for countries to make sure that every single child across these countries can access actually TB care in this manner. And of course, for the countries in red, especially for the availability of the pediatric drug-sensitive TB formulation, those formulations have been available already for quite some time, probably almost 10 years for some of them. So it's a bit worrisome to see that unfortunately not all countries manage to include budget to purchase those molecules or to manage to overcome whatever barriers is blocking access to this key formulation, facilitating the life of the child, but also of their parents and the caregivers. Next slide, please, Adama. So I will move on now to the outcomes of the drug-resistant TB elements of the survey. So there you see that there are 5 elements that we chose actually to be assessed. The first ones are linked to the fact whether bedaquiline and delamanid would be available in the national policy guideline in line with WHO recommendation that are actually recommending bedaquiline delamanid for all ages of children. And you see there are actually there's quite a nuance results, with a majority of countries having updated their guidelines, but not all, which is comforting. And then just also to mention that unfortunately, we know that in some of the surveyed countries, there is an issue nationally linked to the fact that regulatory information, so it means the data that could be provided by the innovators of bedaquiline and delamanid to the national regulatory authority are not supporting the use of bedaquiline and delamanid in all ages. And these regulatory hurdle actually is blocking the update of the national guidelines for the use of those 2 key medicines for children affected by the RTB for all ages. So it's a bit sad because WHO, of course, to move ahead with such a recommendation, it's based on evidences like Stein mentioned it at the beginning of this webinar. So it's not a random at all decision made to recommend use of those 2 medicines for children in all ages. So the fact that for regulatory reason, there's a blockage to the update of the national guidelines is an issue, and hopefully politically within the country, something could be solved to move ahead and make sure those 2 medicines are recommended as they should in the guidelines. Then a third criteria is linked to the fact that injectable medicines are not recommended anymore for children. And it's very much linked actually to the availability of bedaquiline and delamanid for children of all ages. So the 2 are connected. And of course, it's a great move. You can see that the majority of countries have moved already ahead, which is a great news, to not recommend any more injectable in children. And then, of course, nothing of all that would be of impact if the pediatric formulation of bedaquiline and delamanid are not available, and the same for other pediatric formulation for second line for drug-resistant TB are not available, because of course bedaquiline and delamanid are not just 2 compounds to be combined for an efficient regimen for children affected by the RTB. And there, the positive thing is, since last year, every single medicine recommended by WHO to tackle drug-resistant TB is available in a pediatric formulation, and even for most of them in a child-friendly formulation. So it's very important that countries move ahead with securing a budget to purchase those medicines and make sure that there's no barriers preventing them to be available. And I'll stop there and give the floor again to Stein. Thanks.
Thank you, Christophe. Yeah, next slide, Adama. Next slide. Yeah, so you have seen a snapshot of the data now. Quickly, of course. Please have a look to the report. You will find all the data in the spreadsheet in the dashboard. You will also find the narratives, the context, and the messages in each of the 4 chapters, so diagnosing, prevention, DSTB, and drug-resistant TB treatment. And on top of that, when you go to the landing page after the webinar, next to being able to download the report and the dashboard, you will also find the 14 countries that we surveyed. When you click to the flag of each of one particular country, you will find a fact sheet. So what we also did, because we know, I mean, there's so much difference between the countries, also the contexts are different. We made a 2-page summary per country with the given context for that particular country, and then also a snapshot of the data in these country fact sheets. So these are individual downloadable, and we hope these will be useful in your advocacy in the country. Next slide, Adama. Okay. Important to understand, this is a mapping exercise. So what we did, we mapped policies in countries, we mapped implementation status. This is just a start, to be honest, in our way to improve access to TB care for every child. Because I mean, the gaps have been identified. Now we have to work together to solve those gaps and to make sure every single child in the country can access the care of the best quality. That's why at the end of the report, we made recommendations. I will not go one by one because we don't have the time today, but please use those recommendations. There are 3 buckets of recommendations. First, of course, to the countries, the MOH, national policies, that it's important to update the policies, but also to put pediatric TB high enough on the political agendas in the country, and to make sure materials are available to support implementation by the health care centers in the country. So that's on the national side. Of course, countries should not do that alone. They need the support from international funders like the Global Fund, other technical agencies supporting the countries to specifically look to pediatric TB, and not just part as the vulnerable population, but really have a dedicated support to countries to do better, to work on making sure every child can access TB care. So that's a bucket of recommendations for the international funders, for the technical support agencies. Then the last bucket is on civil society. We will hear later in the webinar how civil society can use their voice, and they have a very strong voice in many countries to go to the MOH, to work together with the MOH, to work together with the Global Fund and other funders in the countries to make sure the gaps we see now today are solved as soon as possible. So that's a bucket of recommendations for civil society and affected communities. Next slide, Adama. Okay, and this is the moment supreme. Of course, this is the link to the report. Please, we will share the slides. You will see definitely in the chat the links to be able to download the report. So all the materials are now online since this morning on the MSF webpage. Feel free to download, but also to use it. Please use it as you feel best in your country, in your region, from your institution or organization, to make sure the report reaches the desks and the eyes of the people who should see it, so that we all can work together to improving the policies and the implementation status of pediatric TB care. Next slide. I will hand over now back to Shaylee. Thank you.
Thanks a lot, Stijn, and also thanks to Gabriela and Christoph. Our next speaker will be sharing her experiences of working in MSF mission in Sierra Leone. Her name is Colleen Kernblatt. She is the Humanitarian Affairs and Advocacy Manager of the MSF mission in Sierra Leone. Over to Colleen. Thanks.
Good morning, everyone. Thanks for the introduction, Shelley, and thanks for the great presentation of the survey results to the entire team. Before starting, I wanted to start by also thanking our partner here in Sierra Leone as MSF. We are working very closely with the Ministry of Health, and in particular the National Leprosy and TB Control Program. And I'm sure some of them are online listening to us, and so none of the result I'm presenting now would be possible without them. Next slide, please. So just for a little bit of background, you have a map of Sierra Leone. MSF has been working in Sierra Leone since '86, and some of you may remember there was a very dramatic and long civil war in the '90s. as well as then a quite large Ebola outbreak between 2014 and 16, which both heavily impacted the country in general, but also the health system. Currently, we are supporting the Ministry of Health to focus on children under the age of 5, pregnant women, people affected by tuberculosis, and as well as boosting up the skill of medical professional in the country. We're working in 3 districts, Kenema, Tonkolili, and Bombali. If we can show the animation of the Sierra Leone map. Tuberculosis in Sierra Leone, you'll find more information in the report, of course, but we are considered one of the 30 high burden country by WHO. And based on the estimate, we believe that there is approximately 2,400 children that are ill with TB, but up to 39% of them have missed out on diagnosis and treatment. Specifically in Bombali, MSF has created a project in 2020 in collaboration with the Ministry of Health, where we focused on providing patient-centered drug-resistant TB care in an ambulatory model. But we've also really invested in improved diagnosis, prevention, and treatment for TB in children at primary healthcare level mostly. And with MSF and other partner support, we as a country have been able to roll out new DRTB drug regimen, as well as shorter regimen and a new pediatric diagnostic and testing tool. And as a result, we have 88% policy alignment in that survey. Next animation, please. However, next slide, we know that the policy alignment doesn't necessarily always translate into direct impact and direct services for the patient at facility level. Next slide, please. So doing that survey throughout the year with a national NTP has helped us get more insight into their policies, because of course we were implementing activities, so we knew the practices, but we had not necessarily spent as much effort looking into all of the policy document and all of the training that were used by the NTP over the previous years. So in that, it really strengthened our relationship here in Freetown. It also gave us further leverage, and we were able to validate the new tuberculosis guideline in the country this year, partially thanks to this survey, but also partially thanks to all of the work done by MSF and other partners in the country to support the NTP. This guideline had been in the draft making for up to 2 years, so it's a big success that we've arrived there. Next animation, please. I'm showing you a few examples of the work that MSF has done with an NTP this year. Next animation. And some of the press releases and communication MSF has done at country level on the work we've been doing with an LTCP here. Next animation. And these are the final guidelines. Next slide, please. Now, where are the challenges? Well, that's in the implementation, and that's already been pointed out by previous speakers. It is obviously not a surprise to anybody listening here, but this is what we want to focus on for our advocacy and moving forward. I think the survey can serve as a really good basis of us showing that there is willingness and lots of effort put on the Ministry of Health side to reach and adopt these new guidelines. But however, we are in very low-income countries that is facing difficulties in its budget and implementation capacity to roll out all of these guidelines. So what we've seen with MSF and our project here is that in places where you have a partner that is investing effort into tuberculosis, usually then the guidelines get adopted by the Ministry of Health staff, and a patient in that location get access to the services as they now can be and should be as per this new WHO and country guideline. However, in places where a partner is not working, and there are very little partners that work throughout the 16th district of the country, then things almost stay as they were before the guideline adoption. It needs in-depth support for training, it needs in-depth support for mentoring, it needs in-depth support for review and adoption of new reflexes by healthcare workers. So the algorithm, with a lot of training and MSF follow-up in Bambali district, where we have our project, is now implemented in at least the 15 primary healthcare facilities that have TB services, but not necessarily all of the other primary healthcare services. And out of the district where we are implementing our project, the question remains, with some places being more in line and others being less in line. The sample transport to allow for stool testing to be taking place at the gene expert machine. We have one gene expert machine per district in Sierra Leone. It's in the district capital. But of course, we're in a country where roads are of limited quality and distance are quite wide. And so taking the sample from the primary healthcare facility to the gene expert machine require a whole system to be put in place, which MSF has supported MOH to do in the district, but we haven't done this at national level. We also have always issue with availability of drug at the point of care, where patient might be at primary health care, the drug might be available at the district warehouse, but not necessarily at the point of care where the patient is coming. Another specific concern in the country that is not so much related to all of these new guidelines, but is still a major issue for us is, of course, we know that malnutrition and TB are strengthening each other with negative impact on children. And we are in a country where, sadly, there is quite a high level of chronic malnutrition, and that is not necessarily easily addressed with just an emergency style response of Plumpynut and for a few months and then things are over. It's a chronic problem in the country, undernutrition, and it's actually the identified cause #1 for tuberculosis, including in adults in Sierra Leone. And as MSF, we have supported better integration of TB and malnutrition services in the location where we work, but this is not part of the guideline and the practice in the country. And we are very concerned that treating these children with all of these new drugs and this shorter regimen won't lead to as positive results if it's not done in a patient-centered manner with integrated malnutrition services. I'm sure other colleagues in the chat and other countries that were considered for the survey might also be facing the same issue. And this also requires donors and partners to think about creative way and maybe break down the silos of tuberculosis is on one side and malnutrition treatment is on another, and creating this connection between these separated programs, which have their own separate funding stream. And so this is how we're gonna plan to use this report for advocacy. Next slide, please. I'm just showing you two little examples of the gene expert machine being in a nice district capital in a nice lab renovated by MSF, and the sample transport system on motorbike that we had to create with a cold chain for stability, and I mean, not necessarily cold chain, but at least, right package to reduce contamination and not being exposed to the really high level temperature in Sierra Leone. Next slide. And I wanted to thank all of you for your time, and I'm open for question at the end of the webinar. Thanks a lot.
Thanks, Colleen. Our next speaker is Ghazali Babikar, who's the head of mission and medical coordinator of MSF mission in Philippines. Over to you, Ghazali.
Thank you, and nice to see you all. So a bit not a bit different from the whole topics and the whole issues that was discussed by my colleagues from Sierra Leone, but the context is different, so that the issues are a bit addressed. The same issues, drug shortages, and also issues related to the accessibility to diagnostics and also to treatment. But generally, I would just reflect on the model of care that MSF is doing in Philippines and how we are implementing our projects and how we are looking at it. Just a quick reflection on the country. Philippines is a rapidly economically growing country and has invested a lot in health system and health activities, but yet and achieved a lot in the past 10 years. But yet still there are many gaps and many areas still the country is behind. and that includes communicable disease-specific TB. So Philippines is considered one of the top 10 countries with high burden of TB. Having said that, and in line with that, MSF looking into Philippines because of the situation and the capacity that is available in the country, look into implementation of a special, model of care in the country. So we are doing a community patient-centered model of care that is addressing TB in urban setting. With high density population. Our project is currently in the capital of Manila, in a slum area with high TB burden due to the low socioeconomic status and also the context of the area. We aim to advocate and also think in a holistic approach towards TB, especially in children, to achieve the overall goal that the government has announced of ending TB in the country. Here you'll see on the slide a bit of reflection on our model of care. So it's main 3 pillars or activities with 2 other supporting activities that we are doing. So we are doing actually active case finding, one of the main activities, and that's to improve the detection of drug susceptible TB cases among the general adult population, and also to do contact investigation among household contacts of bacteriologically confirmed cases, TB cases. We do this activity in the access in the SEF through a mobile activity. It's a mobile activities that we move in the different districts, aiming also to reach, to make proximity with the patient and to reach the patient in their location, as this is one of the main challenges that also we will see later on. And we use digital X-ray using CAD, and also we use GenExpert for sputum testing as main or one of the major activity for the SEF. Then after that, we also do linkage to care. So the patient, we have a patient support team or activity that actually they take the results and link the patient to the health centers, and after and also they do household contacts investigation and also diagnosis, and we send them again back to the SEF sites, and we try to make sure and follow their linkage of care and adherence to care or to the treatment, and also identification of defaulters. Also, this activity we are doing also in this model of care, like preventative treatment. So also this is one component of that work we are following. And this is another pillar or another activity. The third activity is actually the health promotion component, where our team do health education at SEF sites, but also they go house to house, they do home visits for education, but also that is extended up to the LGUs or up to the people, in government also, to educate about the disease and also the model of care that we are working. As I mentioned, these are the main 3 activities, but in addition to that, also we do supportive activity as operational research. We did in 2023 study for CAD feasibility, and we have the result, and it was shared with all stakeholders. In 2025, we are planning to be included in tactic study, test, avoid, cure TB in children, and the focus is mainly on the feasibility and acceptability of the shorter regimen of TB for pediatrics in the country. We will come a bit, this shorter regimen, as mentioned by in the survey, is already adopted by the government or by the Department of Health in the Philippines. Still, it's on the phase of implementation. They are running now training for the health centers, staff cadre at regional level, also to educate them about the shorter regimen and how they use the algorithm also. The second supportive activity is advocacy, and that's actually major component of our activity, because we see that there are many resources and many in the country, in Philippines, that can also address the TB better than what is it now. And for that, we are identifying the gaps, the challenges when we implement, and those we can categorize mainly them on access to diagnostic and treatment. And for that, we are building our advocacy strategy around that and try to address issues with the health authorities in the country, but also decision makers. Next, please. So if we go to the challenges, I tried just to categorize the challenges into three main categories. One related to community, one related to policies, and one related to commodities. And for the commodities, it's actually even including the drugs, but also the diagnostics. So for communities, the regular challenges or problem that you see, the stigma, the prioritization, low attendance during the screening activity because of the priorities, delay in treatment initiation due to also limited capacity of gene expert, and also you have unwillingness from asymptomatic patients that they don't want to do the activity or to be seen as TB patient. But again, we have also one big element also is the that will be mentioned also on the commodities, is the shortage of drugs and the availability of the formula that's specific to children. When it comes to the policies, Philippines has adopted, if you see the dashboard of the Philippines on the survey study, but also with the what is reflected is Philippines is one of the countries that adopted most of the policies and to its policies and guideline. I mean the new recommended one. So having said that, still there are some issues in the implementation of these policies on the ground. So for example, shorter regimen for children with TB, it's included in their policies and it's there in their guideline, but then they have some, there are some technical issues or some challenges that they are facing. Maybe it's the time concern. For example, provision of formulation, the dispersible tablets, it's considered and they are working on it. But according to some regulatory process with procurement law, with they are expecting it to have to be in the country the last quarter of 2025. But from now until that time, still will remain the challenge and the issue of how this shorter regimen is going to be implemented. So if we are using the syrup or the single dose, it's question about the feasibility of administration of those drugs also to children in specific. Another one is also the TST exemption or the tuberculosis skin test exemption was included in the policy, in their policy, but still in some areas like TB, high burden community with TB, it still is not very well adopted or looked at. So there is no consideration for those. Like we work in Tondo, and we know the positivity rate in Tondo is very high, and with the context and with the population density, we understand that even from our records and our data collection, that almost 100% of the patient will have TB, especially the contact. So for us, these are practical things that we believe that it should be taken in consideration to get this TST exemption and to allow direct TPT administration to the patients. So in terms of diagnostic, as you know, generally, CAD is not used for children under 15. So there is a bit of a challenge on diagnosis of children, especially that also there is a big problem with the transportation and with accessibility to the X-ray itself for children. And that make it a bit difficult and challenging. also for the patient and family with low socioeconomic status to seek that. So many children left behind without diagnosis, and then that's participate in the mortality rate and the high number of children that are dying because of that. In terms of commodities, it's mainly related to the drug availability in the country. The country has a bit of a system and procurement law that will make it a bit challenging to import and to bring the medication inside the country. And that we have seen that also in our experience since the beginning of this project with recurrent stock out. And we try to identify the problem and to look so related to on the gaps and the issues around that. And it's mainly it's not only the procurement law, there are many other issues related to supply chain, the forecast of the number of the patients at the health center level, plus also, as I said, the procurement law. One other problem, as I mentioned before, is the TB drug formulation available in the country, which is always being has always been the syrup. There is no dispersible tablets available in the country. Next, please. So looking into opportunities, and thanks to the survey activity tactic that supports a bit also on identification of the gap in the country, but also to raise some issues and to engage, allowed us also to engage more with the Department of Health and the authorities to address the different challenges and different issues that we face. So in terms of opportunity, we see that there's a commitment from the government of Philippines to end TB, and for that, we do believe that they are serious about it, but then that commitment needs to be met, and that commitments need also, to be discussed well among the political, level, at the high political and decision maker level, to give more fund and also to invest more on TB in the country. Having said that, still we see though major donors are supporting TB in the country and supporting the government, we do believe on our observation with our experience in the country, at least in our area, is that still there are some areas that could be supported more by the donors. And we don't believe that the country should be left behind, and there should be at least an effort that should be done by the donors to give that support to the government. I know that, for example, some of the donors, they are supporting in the procurement law. Some of the donors, they are also supporting Department of Health on implementation of policies and training, but still we don't see that is very effective. This has been almost for a few years, and we're still at the same stage. So we also urge and ask donors also to pay attention to this and to give the relevant and needed support to the government of Philippines. As I mentioned, with the engagement, also an opportunity that we see is sensitization of all TB actors in the country. We see that still the efforts from all actors together, like civil society, CSOs, patients group, decision media, it's still behind. Yes, they all have the same, feeling about TB, that we should work on TB, we should improve the situation, but still they are lacking behind on the effort that should be done and put together, to address the issues in the country properly. And I believe that also, again, it will go back to the donors, how they support these different groups, but also with the government, how they are open also to look into these problems collectively. Last opportunity that we see, and for us as MSF we are working on, as I mentioned, is the operation research. So we are going to implement the tactical study with our intervention, or at least the implementation of it. Already at the preparation, we have seen good collaboration from the Department of Health and from the government. They're very open, very enthusiastic about it, and that is a good step and forward. And we do believe that with this study, we can have, as mentioned before, an informed scientific evidence-based, that we can use and we can also use in our advocacy to make change in the country. I leave it at this stage, and thank you very much.
Thanks a lot, Ghazali, and also to colleagues who were sharing more information in chat. Our next speaker is Dr. Orioke Ochuko. He's the Deputy Director with the Federal Ministry of Health and Social Welfare in Nigeria. He's the head of the Childhood Tuberculosis Unit and Acting National Coordinator at the National Tuberculosis, Leprosy, and Bruley Ulcer Control Program in Nigeria. Welcome, Dr. Ochuko, and over to you. Thanks.
Okay, so good morning, everyone. I hope you can hear me.
Yes, thank you.
Okay, so I want to start by really appreciating MSF for conceiving, not MSF and everyone that contributed to the conception and a successful execution of this tactic project. And also for your advocacy efforts, even beyond the realms of pediatric TB. By way of background, Nigeria has a population of over 220 million people, and administratively, the country is divided into 36 states and the Federal Capital Territory. We currently have the 6th highest burden of tuberculosis in the world and first in Africa, with an estimated TB incidence rate of 219 per 100,000 population. And that gave us an estimated 479,000 TB cases in the year 2023. Just to also let us know that we also have a high prevalence of and also malnutrition, with undernutrition contributing about 23% of our 479,000 estimated TB cases for the year 2023. Talking about the WHO, the new WHO recommendations, following the release of the new WHO guidelines for prevention, diagnosis of treatment of child and adolescent TB in 2022. I think around February, March 2022, we got the new guidelines, and we were fortunate to also have a national TWG meeting around that period. So we used the opportunity of the TWG meeting to really deliberate on the new recommendations from WHO. And we adopted most of the recommendations in relation to prevention, diagnosis, and treatment, except the one that has to do with 6 months of 6 months treatment for TB meningitis. I think the experts were not too convinced that we should adopt that time. So we adopted all the other recommendations in relation to prevention, diagnosis, and treatment, except that of the 6 months treatment for TB meningitis. And following that meeting, we went ahead to develop a rapid advice on prevention, diagnosis, and treatment of child and adolescent TB, which we disseminated in July 2020. Various meetings, both zonal and at the national level. And following, we asked all our states and implementers to immediately commence the implementation of the rapid advice, which clearly brought out the new recommendations from in line with the WHO guidelines and the operational handbook that followed the release of the updated DEX guide for prevention, diagnosis, and treatment of TB in children and adolescents in March 2023. Since then, we've been implementing these new recommendations, both for the shorter TPT regimen, vaccine-based regimen, the shorter 4 months moxifloxacin-based regimen for children above 12 years, and even the ones for drug-resistant TB. Not also forgetting the 2 treatment decision B. And we followed up with an operational research component for the treatment decision algorithms with the support of WHO, both the WHO Global TB Program and WHO TDRO. They supported us to incorporate, and we conducted across 6 states and across the 3 levels of healthcare facilities, primary, secondary, and tertiary healthcare facilities, with a focus on task shifting of child TB diagnosis to nurses and general healthcare workers at the PHCs. And I must confess that the preliminary findings from that research has been quite encouraging, as we are currently working to publish the findings from that study called the Veduta study, which was on evaluating the performance, the feasibility, acceptability, and impact of the treatment decision algorithms across the 3 levels of healthcare in Nigeria. And we had about over 1,000, I think 1,000 participants for that study. And like I said, the findings are really encouraging. And all these efforts, I hope you can hear me.
Yes, we do.
All these efforts have actually helped in improving child TB response. And for the first time in the year 2023, we're able to notify about 36,000 pediatric TB cases as a country, far, far higher than the just 20,000 that we notified in 2022. So yes, we've been able to, the new recommendations have really helped us in helping to step up our pediatric that we've implemented. Talking about the challenges, I must confess that we also have challenges with implementation. It has been highlighted by other speakers. One is that healthcare workers do not feel confident to use those algorithms if there is no formal training for them. And that has not happened across a large segment of the country. So yes, we have capacity gaps amongst healthcare workers at all levels in implementing the TDAs and all the other recommendations, including the shorter prevention and treatment regimens. We also do not have enough copies of these tools, talking about the rapid advice, the DEX guide, to disseminate to the over 40,000 health facilities that we have in Nigeria. So these documents are not readily available for the healthcare workers to make use of them. And of course, the issues around uptake of the TB preventive treatment, parents refusing their kids to take the shorter regimen. So we're also working around promoting social behavioral change communication around the use of preventing TB in children. But just for me to round up by saying that, yes, as a country, we have the policies, we have the technical expertise to be able to implement these policies. But when it gets to the facilities where the action should actually be taken, we have that gap with building the capacity of the healthcare workers to be able to really scale up the use of these algorithms across the country. So we're using this opportunity to call on the multilateral agencies, the bilateral agencies, UN organizations, the donors, to be deliberate in providing resources for pediatric TB control, for us to be able to really make that drastic change that we desire. There has to be deliberate investment for prevention, diagnosis, and treatment of pediatric. Thank you for listening.
Thanks a lot, Dr. Chuko. Our next expert intervention is by Ms. Gloria Moses, who works as Citizen Science Program Officer at International Treatment Preparedness Coalition as an ITPC Global, as many of you know. And also she's an emeritus member of Global TB Community Advisory Board. Yeah. Over to you, Gloria.
Thank you so much for the introduction. I'm going to try and keep my camera off, so it seems my internet is a bit off. But I guess my role here today is sort of give perspective as a community representative on what I think the next steps for us will be. So what are the practical things that we can do? Just to start off, just to say thank you so much for doing this amazing study and for taking the time to try and put pediatric at the center. I think most often we forget that pediatrics exist. We often treat them as mini adults. So we assume what works for us adults is going to work for pediatrics. So it's very important that you have this session for us to be able to have this conversation. And I think it was summarized very well from the Philippine conversation, some of the key gaps and challenges that you have seen in the survey, things around stigma, things around stockouts. So these are things that we experience on the ground. And I think as communities, we have this unique experience of lived experiences and expertise that we can bring to you. We experience this real hand, and we can give you the information where it pinches most. So for giving us the space to sort of give our ideas on what we think this can go forward is very key. And again, as I give these practical steps, just to mention that it's not the same for all countries, so it's going to be different for the different contexts. We all have unique backgrounds where we're working from, but I think these are sort of practical ways that we can take this conversation forward as communities. I want to start by saying that the data is scary to look at it. We've made a lot of advancements in the TB response, but it's still scary to look at the numbers and you see reds, and it's young children who cannot come in and tell you this is not working for us. So you have to sort of rely on the parents and guardians to give you the information. So it's a bit scary for us to look at it and see we still have reds in a majority of the countries. And we know this data in itself, by looking at it, it won't change anything. We sort of have to have a conversation. How then do we make the best efforts to be able to change the situation? First, to sort of start it off on what I think communities we can do, one of the things that I think we should immediately is package this information. So there is these big graphs that we've seen. We have seen a lot of acronyms here and there. How do we package this information for our communities? If I'm working in a context in Tanzania where we use Swahili as our language, how do I contextualize this information as a community person for them to be able to understand? The other part is, we have WHO guidelines, we have national policies that we have in our context. How do we make sure that they align and they speak to each other? We've seen cases where WHO guidelines are saying we should be implementing shorter regimens, but in reality, this is not happening. So then how do we marry these two and ensure as communities we are advocating for the inclusion of a marrying of the guideline? The second part is community responses. And I think I've mentioned before, as communities, we have this unique role and we have this unique expertise we have the lived experience, we have seen children with TB, so we understand where they're coming from. So using this expertise, how do we create community responses and how we plug into existing healthcare systems? So if you're having an issue with people accessing services because the services are so far away, how do we come in as communities and plug in and ensure that, we are there to support advancement of services? Someone doesn't have to travel 5 miles. So there's decentralization of services, whether it's to do community models. And I think this is very key. And if you look at the HIV space, they have done things like community ART groups where people don't have to travel miles away to get treatment. So can we have the same models, and and they don't have to be the same ones, but then looking at context, how do we ensure that we have models that speak to our communities and respond to the needs that they have? The other part is we have different tools and resources in our arsenal as communities. For instance, we have community-led monitoring, which is a science in itself and innovation that sort of comes in and says, this is not working for recipients of care. When I access services, yes, the service is there, but it's not quality. It's not acceptable for me. Is it affordable? So taking in what the different tools we have, community-led monitoring that has been very instrumental in holding duty bearers to account, and it's not a fault-finding mission. So it's sort of saying, this is what as a recipient of care we're experiencing, and we are coming in and we are telling you, this is not working for us. So how then we have a conversation using these tools, CLM, community responses, to be able to advance services for our pediatric children. Health education is very key. And I think, again, we've seen it today. There are very many acronyms that I've seen today as well that I don't know. So how do we sort of break this down and give the health education to our communities? I mean, we come here and we have beautiful presentation, we have beautiful terms that we say, but sometimes we are not communicating to our target audience. So you're saying you have CAD, you have, I'm trying to remember the ones I've seen, but you're saying you have all these beautiful machines, you have all these things that you've made, but we don't understand what it is. So it makes it very hard for me to come in and seek a services that I don't understand. So allocating for resources and creating resources that go into supporting communities in doing treatment literacy, in learning the normative. What is TB? How do I get TB? How do I prevent it? When I get it, what does treatment look like for me? And when I'm treating my child, it's probably different from how I treated it. Because sometimes you use, and again, as I said, adults, you use the information you have about yourself to treat the child. So you're saying, this is what I did when I had TB. So this is what I'm going to do with my child. And that's not necessarily what is supposed to happen. So then how do we break this information and make sure that we have the right information and we're giving the right information to our communities? Structured advocacy, of course. I know you've mentioned that you're going to do advocacy, but I mean, advocacy has to start from the community side. So structured advocacy, we've seen the case studies, we have seen the gaps, and I think the other challenge is it's just for specific countries. So we are for 14 countries. What about the other countries? So then how do we get data for the other countries, and how do they come in and be able to do the advocacy for themselves? Because sometimes you advocate, you have data that you saw from India, but it doesn't work for the Kenyan context. It's quite different. So then how do we ensure that we are integrating the indicators that you have into community programs, into community-led monitoring programs, and ensuring that we have all these indicators harmonized for communities to be able to have this data in the tip of their hands to do advocacy. And necessarily it's not comparative advocacy, it's advocacy for me to come and tell you, this is not working, this is, I think, what we can do. So it's conversation, it's not necessarily us fighting, but we're having a conversation. Stakeholder engagement, I know today we've had the National DP program, you have the community representative, but also there are other stakeholders that we can bring in. We have the private sector. So how then do we create space for them to come in and be able to sort of tell us, as a private sector, this is where we can support you, as communities, it's where we're supporting you. So it's a conversation that we need to hold, and this can be led by community. And as I said, communities are at a unique position where you come in, there is no sort of, it's you coming with expertise and it's lived experience. You're saying, this is what I experienced. So as a private sector, how can you support me? As MSF, how do you support me? As Global Fund, how do you support me to be able to access these services? Again, communities, we can support and we can do monitoring for you. That's one thing we're very good at. We have the tools, as I said, we have community-led monitoring. We can monitor the services and we can tell you, you know what, this is not working. So as you're doing these surveys, how do you also help us to include, you have the question that you developed, how do we include this in our community responses? Ongoing monitoring and accountability, this does not have to stop here. I know sometimes we do a survey and then it takes 5-6 years to do it again. So then how do we make sure that this is something that is ongoing. It's routine. It's not a one-off event and then we are off. You're like, these are the challenges. We're going to fix them and we're going to come back after 5 years to monitor. So then how do we do routine monitoring, and how do we ensure that communities who are accessing these services are the ones who are doing monitoring for you? So they're telling you, these are the gaps you saw 3 years ago. In 2 years, you've done this. This has not worked. This has worked. How do you better improve services? Which then brings me to my request, and I guess our call to action for communities and to you partners and other stakeholders. One is to continue doing technical assistance. You have done the survey, of course, you have the data and you understand the data better. So we can't tell that we can take the data and just use it. So how do you help us to understand this data and use it for advocacy? So here comes in resources for advocacy. Don't shy away from giving resources for advocacy. It's not going to be a fight. It's going to be a conversation where we come and we say, you know what, you saw these challenges. This is what we are seeing. This is what we can do. So it's an ongoing process where you are investing in the conversation, and then we're coming in with that expertise to help you. We have right now a CLM pilot project for pediatric, and we are working with GTCM, where we are saying, we've seen CLM that has worked in HIV, in TB for adults, but we have not had a specific focus for pediatrics. So what are these findings that we are seeing? Is it something that we can take, because it's a pilot project in 2 countries, in India and South Africa. So how do we take this pilot project and include the findings that you have from the 14 countries and marry the two and make sure that we are speaking the same language, we are speaking that these are the findings that we are seeing, and this is how we move forward. Collaboration, of course, it has to be there. So we have to do collaboration as we go forward. But that's just one way of doing it. How do we make sure that it's structured coordination and collaboration? So everyone knows their role, everyone knows where they come in and how they support. As I end, I want to mention that communities are experts, and whether you're thinking advocacy, you're thinking accountability, you're thinking monitoring, those are expert skills that we bring to the table. So now that we have presented this expertise to you, it's for you to use them and utilize them as we're offering them. Just as I end the conversation is, I want to end with a saying that says, every child that has TB has an opportunity to not only survive, but to thrive. So then how do we come all together and ensuring that we are not only making it survival and it's not us trying to make sure that the child survives beyond TB, but also they can thrive and go beyond having the conversation about TB and go into their better selves. Thank you so much, and over to you.
Thanks a lot, Gloria, for such a clear roadmap of communities engagement, in fact, and we're really looking forward to collaborating with you in future. Our next speaker is Kerry Aveni, who leads the work on TB, HIV comorbidities in at-risk population, including children and adolescents, at the WHO Global TB Program. Over to you, Kerry.
Thank you very much, Shirley, and I hope I'm audible. All okay? Yep, great, thank you. Well, firstly, thank you very much to the MSF team and the Tactic Project for the invitation to participate in this webinar. Very well attended. I think we had over 200 people at the peak of the webinar. And we'd like to congratulate MSF on this survey of policies on the management of TB in children and adolescents in 14 countries, and for amplifying our work and evidence-based recommendations to improve the care of children and adolescents either with TB or at risk of TB. Now, I think the outcome of this analysis shows that it takes some time for countries to update and implement their national guidelines in line with global policy recommendations. And there's sort of patchy uptake of some of the recommendations. And essentially, this means that we have to keep our sleeves rolled up, and we all have a lot more work to do. So in terms of what WHO has been doing, almost 1 year ago in November 2023, we launched the 3rd edition of the roadmap towards ending TB in children and adolescents. And this is fully aligned with the targets of the political declaration of the 2023 UNHLM meeting on the fight against TB. Now, the roadmap includes 10 key actions to move us towards ending TB in children and adolescents, as well as in pregnant and postpartum women. And the topic of this webinar today, which is really about closing the policy practice gap, is heavily emphasised throughout the roadmap. Now, I think in this webinar, we know that certain conditions facilitate the uptake of WHO policy recommendations, and I think Dr. Ochuko very nicely described some of these. So some of these might include having a focal point in the TB program for the management of TB in children and adolescents, having a national technical working group, which Dr. Achuko described, which has a broad range of public and private stakeholders, including representation from the National Pediatric Society, ensuring that the needs of children and adolescents are reflected both in the National TB Strategic Plan, but also in other plans, such as child health plans, having a focus on TB in children and adolescents in program reviews, having dedicated funding and resources, of course, in the funding applications, which has been mentioned, access to the child-friendly formulations as included in the essential medicines list, and also the much-needed capacity among healthcare workers coupled with supportive supervision to implement the recommendations. And I think as Gloria has very nicely described, of course, it's also essential to involve communities and civil society organisations in these efforts, starting from planning right through to monitoring and evaluation, and having that in place at the global, national and the local levels. And I think it's important to remember that communities always contribute from the perspective of people, and keeping people and children at the centre of the TB response, which is, of course, our goal. Now, in terms of some of the other things that WHO has been doing, just thinking about capacity building, we have issued 2 e-courses which are available on Open WHO, one for healthcare workers and one for a programmatic audience. So these are e-courses on the management of TB in children and adolescents. They're available in English and will soon be available in French. And we can also provide the package for translation into local languages upon request. And Gloria just highlighted this for Swahili. Now, since the launch of the guidelines and operational handbook on the management of TB in children and adolescents in 2022, which we've spoken about in this webinar, WHO has convened other guideline development group meetings, which will lead to new recommendations related to the management of TB in children and adolescents. There are some important updates about to be announced. And I think most people are aware that prior to publishing a new guideline or handbook, WHO does publish what are called rapid communication documents. And they really announce the upcoming changes to member states and key partners so that people can prepare to implement new WHO recommendations. We don't have a lot of time now, but there are a number of important updates that are coming. So just to very briefly signal some of these, in September, so just last month, WHO released updated guidelines and a related operational handbook on TB preventive treatment, which Gabriella covered very nicely. This has one new strong recommendation on the use of levofloxacin for 6 months as an option for TB prevention among people of all ages exposed to multi-drug resistant TB. And as Gabriella already mentioned, 3HP is now recommended for all ages. Also in September, there was a rapid communication on TB diagnosis, and this has important implications for children being diagnosed with TB, because there will be upcoming recommendations on the use of concurrent tests for the diagnosis of TB in children, as well as adding LF-LAM for children living with HIV. So that will soon come out. And then Colleen and others have spoken about nutrition. So in June, July this year, we convened a guideline development group meeting on TB and nutrition. There were a number of questions about the provision of nutritional interventions to people with TB and their household contacts. And a rapid communication has been developed and will come out soon. So of course, that will also be relevant to children with TB and household contacts who are children. And then finally, in terms of the guideline updates, I think many of you are aware that we held a guideline development group meeting on the treatment of drug-resistant TB in June. And then in August, a rapid communication was published by WHO. And this announces some new regimens, so a 6-month regimen based on the evidence from the BEAT TB trial and 3 9-month regimens based on the evidence from the NTB trial. And importantly, this means that a 6-month regimen will be available to treat multi-drug resistant TB in children, because the BPAL regimen can only be used in those age 14 and above. Then in addition, we've issued guidance on social protection, of course, which is also important for children and families. And we're working on an update to Module 5 of the Guidelines and Operational Handbook on the Management of TB in Children and Adolescents, so that all of these new recommendations are aligned. And then I think we're just at time, so we'll try and wrap up quickly, Shelley. So just to emphasize a couple of final points as well, there is ongoing implementation research, which I think has already been spoken about, in order to accelerate uptake of the treatment decision algorithms. So WHO and TDR have developed a research package called TDA for Child, which MSF has taken that up as well. And there are 18 groups who are doing this research, including in 13 countries, with a total sample size of over 20,000 children with presumptive TB. So that research is ongoing. We're also hoping to start some research in collaboration with TDR to look at uptake of the 4-month regimen for non-severe drug-susceptible TB in children, because there are some barriers to the uptake of that regimen, and we'd like to sort of get to the bottom of what those barriers are and overcome them. And then finally, just to conclude, on 29th of October, WHO will launch the Global TB Report 2024. And this will, of course, include updated data related to TB in children and adolescents. And we'll be doing a deeper analysis of these data, which will be presented during the annual meeting of the Child and Adolescent TB Working Group on 11th of November in Bali, just ahead of the Union Conference. And there will be a hybrid option. So anyone on this webinar is certainly welcome to join in. So with that, I'd just like to thank MSF again, and to all of the excellent speakers and presenters. It's been really a fascinating webinar, and thank you for your attention on this important topic of TB in children and adolescents. Thanks so much.
Thanks a lot, Kerry. And thank you for sharing all this very pertinent information about upcoming guidelines and also about Global TB Report. I noticed that our colleagues were actually responding back to most of your questions. First, apologies for going way beyond. I mean, we're already pretty past that schedule that we had. I don't know if our speakers want to share more about questions being raised in the chat, and or want to just add something based on discussions that are happening on the chat. I invite all the speakers now. Jane, maybe?
Yeah, thank you, Shelley. And maybe just a final word, because I don't want to hold you too long in the webinar, although we shared so much information. I mean, we can spend the whole day basically together to discuss the findings and the ways forward. Just one final word, and it relates also to the question from Martina in the chat on the ECPAF survey, like a few years before us. Also, Stop TB is doing, I believe, every year now a survey on policies in countries in TB in adults and in children. So I would really suggest that we combine all those things and learn from each other, work as a community together, based on the different surveys doing in different countries, to really work together as a community to find the solutions, to work with technical agencies, to work with the MOH, and really as a community towards closing those policies gaps that we identify in our survey, that also in the ECPAF and the Stop TB survey are very clear, and also together with WHO to really work together towards closing policy gaps. But also, as I said in the chat, it's not only about the policy, because that's basically a book on the shelf. We really want to see changes on the ground to work towards implementation. There are a lot of barriers, we know that, but I think we can do it. And if we work all together towards identifying the barriers, which can be very local and context specific, together with the country teams, but then also work towards solutions with all the actors involved. So that's the only thing I wanted to add to the many things already discussed in the chat, Shelley.
Thanks a lot, Stein. And I think we'll wrap it up for now. We'll share the recording and presentation with everyone once the webinar is over via email. I would like to give special shout out to Ed and Adama, who had been helping us out in managing this webinar so well. We'll also share contact details. I see people are already sharing. We'll share contact details of all the speakers as well, if they are okay with that. Also would like to thank Tiziana Massini for her excellent coordination of the survey design, and Yannicka Hauser, who actually helped us write this fantastic report on behalf of Tactic Team and MSF Access Campaign. And special thanks to all our external speakers, Kerry, Dr. Chico, and Gloria. Thanks a lot. All right, bye-bye.